All right, so you're in the ICU,
Mm-hmm.
right? And you see those lines going into patients' wrists.
Mm-hmm.
Those are radial arterial catheters. RACs is the shortcut. They're like essential and critical care. But they can fail a lot. Did you know that?
Yeah, it's true. Almost a quarter of them fail.
Wow, really?
It's a big deal. Impacts patients' safety, how well their treatment goes.
Right?
That's why this article, 10 Best Practice Tips for Arterial Radial Catheterization from the Journal of Vascular Access, is so important.
Okay, so we're diving deep into these RACs today then.
We are. This article, it's practical, it's based on evidence, and it's not just about putting the catheter in, it's everything. The materials, the aftercare, everything.
This is going to be good. Hit me with tip number 1. What's the big secret?
Ultrasound guidance. It's not just a fancy extra, it makes a huge difference. Studies show if you use ultrasound to place it instead of just, feeling around,
Yeah.
your first try success rate goes way up.
So less poking patients, which they'll definitely appreciate.
Exactly. Less pain, fewer complications.
Makes sense.
Yeah.
So what kind of complications are we talking if it's not placed right?
Well, it could get blocked, dislodged. You might get inaccurate readings, could even lead to infections.
Oh, yeah. Not good.
Not good at all. And ultrasound isn't just for the first try. It helps you pick the right size catheter, see how the blood's flowing, even avoid any tricky spots in their anatomy.
So it's like the go-to tool for this whole process.
Pretty much. This one tool impacts so many parts of placing and managing the RAC.
Huh. Okay, what about that Allen's test? I remember that from way back.
Ah, yes, the Allen's test. It's supposed to make sure there's enough blood flow to the hand before you put the catheter in.
Right.
But, and this is important, the article points out, it might not be as reliable as we thought.
Really? Why is that? Seems simple enough.
Too much depends on what the clinician sees. One person's flush is another person's
Subjective.
Exactly. So, inconsistent results.
What's the alternative then? If it's not reliable enough?
Arbo test. Much more objective.
Right.
Uses a few techniques combined, like Doppler ultrasound or plethysmography. Plus, it checks the pulse oximetry.
So, more tech to the rescue.
You got it. Objective measurements mean better decisions, lower risk for the patient.
Gotcha. All about minimizing those risks.
Absolutely. Which brings us to a tip that might surprise you. Skin assessment.
Wait, really? So it's not just about getting the catheter in, it's what happens after.
Exactly. You got to take care of that site. The article really stresses that skin complications, they happen more than you'd think.
Huh. Like what kind of complications?
Redness, swelling, bleeding, could even be signs of infection.
And those can become serious, huh?
Oh, yeah. Affects the patient, affects the whole procedure.
Okay, so how do you avoid that?
Meticulous hygiene. Really got to be careful with the dressing, and you got to keep an eye on that site for any changes. Catch it early. That's key.
So small detail, big impact.
You got it. And it's not just about avoiding problems. It's about making the patient comfortable.
Makes sense. Okay, so far we've got ultrasound, double-checking the Allen's test, and being super careful with the skin. What's next?
Let's talk about the patient's comfort. Article's really big on local anesthesia.
Makes sense. Needles aren't exactly fun. Absolutely. Using local anesthesia is a win-win. It's about improving patient comfort, which leads to better outcomes for everyone.
You're exactly right. The article explores different types of local anesthesia that are most effective for arterial cannulation, like lidocaine or mepivacaine for infiltration. They also mention using refrigerant sprays, vapocoolants, and even topical agents like gels, creams, or patches.
It sounds like there's a whole toolkit for pain management. Why is pain control so important for RAC success?
It's not just about making patients feel better, although that's a priority. Pain and discomfort can lead to movement, which can dislodge the catheter or make it harder to place correctly in the first place.
So a relaxed patient means a better chance of getting the catheter in the right spot and keeping it there.
Exactly. It's all about creating the best conditions for a successful procedure.
Okay, we're halfway through these best practices. What's tip number 5 about?
This one dives into a bit more technical aspect. The catheter to vessel ratio, or CVR.
That sounds technical. Like threading a needle inside a blood vessel. How do you pick the right size?
Imagine a highway. Too many cars, and you get a traffic jam. The CVR is all about ensuring smooth blood flow around the catheter.
So it's about finding the right fit for the vessel. Not too big, not too small.
Exactly. The article suggests maintaining a CVR of less than 45% to minimize the risk of complications like thrombosis.
Thrombosis sounds serious. What causes that?
Thrombosis is basically a blood clot. If the catheter is too big for the vessel, it can disrupt blood flow and increase the risk of a clot forming.
That makes sense. So how do you determine the right CVR? Is it just eyeballing it?
Not at all. This is where our friend ultrasound comes in handy again. It allows for accurate measurement of the vessel diameter so you can choose the most appropriate catheter size.
Ultrasound is the gift that keeps on giving in this field. I'm starting to think of it as the Swiss Army knife of RAC insertion.
It's definitely an invaluable tool. And speaking of tools, let's move on to tip number 6, the angle of insertion.
There's an ideal angle. I'm picturing those geometry problems we all struggled with.
Think of it like parking a car. The right angle makes all the difference. The article emphasizes lower angles of insertion, less than 30 to 45 degrees, to reduce the risk of kinking.
Kinking.
Yeah.
Like bending the catheter.
Exactly. And a kinked catheter can obstruct blood flow or even break, which obviously you want to avoid.
Definitely. So how do you ensure you're getting that perfect angle? More ultrasound.
You got it. Ultrasound helps visualize the vessel and guide the needle, but they also mention using trigonometry to calculate the optimal angle based on vessel depth.
Trigonometry. Didn't think we'd be revisiting high school math here, but I'm here for it.
It's all about bringing together different tools and techniques for the best possible outcome.
Okay, this is fascinating. We're learning so much about the nuances of RAC insertion. What's next on the list?
Tip number 7 focuses on catheter length.
This seems counterintuitive. Wouldn't a shorter catheter be easier to manage?
You'd think so, right? But it turns out a longer catheter, when placed correctly, offers several advantages.
Okay, I'm intrigued. Tell me more. What are the benefits of going long?
A longer catheter means more of it sits securely within the vessel, leading to better stability and stronger waveforms.
So less chance of it slipping out or getting jostled around. That makes sense. Anything else?
Yes, it can also result in longer dwell times.
Dwell times, meaning the catheter can stay in place for longer.
Precisely. And longer dwell times mean fewer catheter changes, which translates into less discomfort for the patient and fewer opportunities for complications.
Okay, I'm convinced. Longer it is. But how do you determine the ideal length?
The authors recommend considering the radial artery depth and angle of insertion to ensure that at least 65% of the catheter is inside the vessel.
So again, it's about finding the right fit for the individual patient.
Exactly. Every patient is different, and a one-size-fits-all approach simply won't cut it in this field.
Okay, we're on a roll. What's the next tip on this list of best practices?
Now we're getting to the nitty-gritty of materials. Tip number 8. Not all plastics are created equal when it comes to catheters.
Wait, the material matters too. Like,
Yeah.
is one type bouncier than another?
You got it. We're talking about the properties of the catheter itself. The article compares polyurethane, or PUR, catheters to those made from polyether block amide, or PBA.
Okay, so what's the difference? Why would one material be better than another?
It all comes down to flexibility and kink resistance. They point out that PUR catheters, while common,